Dear students, I'm Rəhimə Qabulova, Associate Professor at the Department of Propedevtik of Internal Disease, and the topic of our lecture is Anatomo-Physiological Features of Hepatobiliary System, main semiology of hepatobiliary system diseases, and the diagnostic value. The liver is the largest parenchymal organ of the body. It is located in the right hypochondrium and held in the place by several ligaments, but mainly by force of intra-abdominal pressure. The liver is grossly divided into two portions, right and left lobe, as viewed from the front diaphragmatic surface, but from the underside is divided into four lobes and includes the caudate and quadrate lobes. The pear-shaped gallbladder lies beneath the liver. Gallbladder receives nearly 50% of the bile produced by liver via the cystic duct. The rest of the bile flowing through the common bile duct, converging with the main pancreatic duct, passing through the pancreatic head and emptying into the duodenum through the sphincter of Oddi. Blood supply. The blood flow to the liver is around 20-25% of the total cardiac output. The liver receives a dual blood supply, and blood is carried into the liver via two large vessels called the hepatic artery and the portal vein. About 20% of blood coming from the hepatic artery and 80% from the portal circulation. The hepatic artery carries oxygen-rich blood from the aorta. The portal vein carries blood containing digested food from the small intestine. These blood vessels subdivide in the liver, repeatedly terminating in a very small capillaries. Each capillary leads to a lobule, and liver tissue composed of thousands of lobules, and the lobule is made up of hepatocytes. The liver lobules are roughly hexagonal and consist of plates of hepatocytes radiating from the central vein. The central vein joins to the hepatic vein to carry blood out of the liver. A distinctive component of the lobule is the portal triad. It is located in the corner. The so-called portal triad actually consists of five structures: this branch of the hepatic artery, branch of the portal vein, and the bile duct, as well as the lymphatic vessels and the branch of the vagus nerve. Between the hepatocyte plates, there are the liver sinusoids. They are enlarged capillaries, and blood from the hepatic portal vein and hepatic artery enters portal triads and then drains to the central vein. And the flow of blood is from the outside to the inside of the lobule, but the bile flows through the small canaliculi from the inside of the liver lobule to the outside. Liver carries out more than 500 essential tasks. The major function of the liver include bile production, which breaks down and absorbs fats, cholesterol, and some vitamins. Homeostasis, the liver parenchymal cells produce most of the factors and inhibitors of the clotting and fibrinolytic system. The liver has a central role in control of lipid metabolism, as a biliary secretion of cholesterol and phospholipids from the liver into the intestine. They place major importance in lipid homeostasis. The liver is the major source of the plasma lipoproteins, liver synthesis enzymes, and finally liver is the site of the active synthesis, metabolism, and oxidation of the various lipid classes. The liver plays a unique role in controlling carbohydrate metabolism, and by maintaining a glucose concentration in a normal range. Carbohydrates are stored in liver by glycogen and releases whenever the quick burst of energy is needed. Vitamin and mineral storage is another important role of the liver. It stores vitamins R, D, E, K, and B12. It keeps significant amount of these vitamins stored. The liver stores iron from hemoglobin in the form of ferritin and copper in the form of ceruloplasmin. The liver Plays a role in the amination and transamination of amino acids, and the hepatocytes are responsible for synthesis of the most of the plasma proteins. Albumin is the major plasma protein, which is synthesized by the liver. It transports fatty acids and steroid hormones, and also it helps to maintain the oncotic pressure of blood. The liver filters and removes compounds from the body, including hormones such as estrogens, aldosterone, as well as the alcohol and other chemical substances. Removal of ammonia from the body by synthesis of urea is one of the important roles of the liver, because ammonia is very toxic, and if not rapidly and efficiently removed from the circulation, it results in encephalopathy. Immunological function is the major role of liver as well. The liver is a part of the mononuclear phagocyte system. It contains high number of the Kupffer cells, and they are involved in immune activity. The liver has a remarkable capacity to regenerate after injury and to adjust its size to match its host. And a brief information about bilirubin production and metabolism. The body usually produces about 300 milligrams of bilirubin per day as a breakdown product of HEM. About 80% from red cells and from other proteins as myoglobin and cytochromes. Bilirubin is insoluble in water and is carried in plasma bound in albumin, and normally is not filtered at the glomerulus. In the liver, unconjugated bilirubin is conjugated with glucuronic acid by the enzyme glucuronic transferase, making it soluble in water. It goes into the bile and then it into small intestine. Conjugated bilirubin passes into colon. Colonic bacteria, they conjugate and metabolize the bilirubin into colorless urobilinogen. It can be oxidized to urobilin and stercobilin. Urobilin is excreted by the kidney to give urine a yellow color, and stercobilin is excreted in the feces, giving stool its characteristic brown color. A very small percentage of urobilinogen is reabsorbed into enterohepatic circulation and is re-excreted in the bile. Examination of patients with liver disease. It consists of subjective examination or history taking, objective examination, and which consists of visual examination. It also subdivided into general inspection and local inspection, percussion of abdomen, palpation of the liver, gallbladder, spleen, auscultation of the abdomen, and preliminary diagnosis, supplementary examination, and setting of the final diagnosis. The patient with disorders of hepatobiliary system usually complain of abdominal pain, dyspepsia, loss of appetite, bitter taste, meteorism, nausea, vomiting, constipation, diarrhea, jaundice, itching or pruritus, abdominal swelling due to ascites, dark urine, pale stools, fever, chills, unexpected weight loss, general debility, fatigue, headache, trembling, mood change, sleep disturbances, loss of sexual drive or erectile dysfunction, gastrointestinal bleeding, and liver cirrhosis. The pain is one of the most common complaints of patients, and it is important to consider the following characteristic of pain as localization, radiation, character, duration, aggravating and relieving factors. Pain is located in the right hypochondrium and sometimes in the epigastrium. Pain may be persistent and dull, or it may be severe and occur in attacks. The persistent pain is usually boring, or the patient feels pressure, heaviness, or distension in the right hypochondrium. Pain may radiate to the right shoulder, scapula, and the interscapular space when the process extends onto the peritoneum overlying the liver and gallbladder. Or sometimes it may be due to the rapid and considerable enlargement of the liver, and which causes distension of the Glisson's capsule. Pain usually becomes more severe in deep breathing, in adhesion of the liver or the gallbladder to the neighboring organ. Pain is also intensified when the patient changes his posture and sometimes during walking. Attacks of pain or biliary and hepatic colics develop suddenly and soon become quite severe and unbearable. The pain first localized in the right hypochondrium but then spreads to the entire abdomen. The duration of pain, there may be continue from several hours or few days, during which pain may subside or then intensify again. Attack ends suddenly and pain may lessen gradually. Attacks of pain occur mostly in gallbladder stones or cholelithiasis. They are provoked by jolting or by fatty food. Pain attacks occur also in hypermotoric dyskinesia of the gallbladder and bile duct. Pain usually develops quite unexpectedly due to the spastic contraction of the muscles of gallbladder. Sometimes the cause of pain is the irritation of mucosa or by the stone, sometimes due to obstruction of the common bile duct by a stone, hot bottle or the liver, to the liver, and also administration of the myospasmolytics remove colic pain. An attack of the hepatic colic can be accompanied by the subfebrility and jaundice. Pain developing in dyskinesia in the bile ducts is associated with the upset coordination between the contraction of gallbladder and the Oddi sphincter, this convulsive the contraction. They never characterized by the signs of inflammation. Gastrointestinal bleeding is one of the dangerous symptoms of hepatobiliary system disease, and mostly the causes are parenchymal bleeding due to the liver failure, vitamin K and prothrombin deficiency, rupture of the esophageal varices, which is related to the portal hypertension, which is the serious complication of patients with liver cirrhosis, and combined mechanism. If larger amount of bleeding occurs, symptoms may include the black tarry stools bleeding for esophageal varices, and bloody stool bleeding from hemorrhoidal veins, and vomiting or hematemesis, lightheadedness and paleness. These two symptoms, the last two symptoms, are specific for the anemia. Then collecting anamnesis or history of the present illness or anamnesis morbis, it is necessary to find out the information about the onset of disease, causes, course and development of disease. Laboratory and instrumental examination were carried out and their results, the previous treatment and drugs, and the dosage, reasons of the current hospitalization. The life history of patient or anamnesis vitae. When inquiring the patient, it's necessary to establish factors that might be important for etiology of the present disease of the liver or bile ducts. The first is working and living conditions, history of past diseases or infective hepatitis, for example, dietary habits, overeating, fatty foods, exposure to chemicals and vegetable poisoning, for example, the poisoning with mushrooms, which contain strong hepatotropic poisons, bad habits, for example, alcohol intake, family history, cholelithiasis, Gilbert syndrome, hematochromatosis, and Wilson disease, diabetes, contact with an infected person, recent foreign travels, sexual history, operations, and blood transfusions. These are important information for defining the cause of the present illness. Visual examination is objective examination method which is carrying out in two steps. First is assessment of the patient general status, this is the general inspection, and second is the local inspection. And this slide demonstrates the variety of symptoms in liver and gallbladder diseases, and the general condition of the patient is first assessed, and the patient condition may be grave or satisfactory depending on the severity and the time of the patient's disease. Mental condition and coma are present in severe liver diseases, and the severe disease may lead to fetor hepaticus and flapping tremor. And then the jaundice is specific for gallbladder and bile duct diseases, also for the hepatic diseases, disease of the liver, and the xanthomas, xanthelasmas, Geyser-Fleischer ring, atrophy and tongue, and other symptoms, they will be further discussed. And on visual examination, the certain signs will be found which are suggest for chronic liver disease, and these symptoms are shown on this slide. An important symptom for diagnosis of chronic disease of liver is spider angiomata or spider nevi. They're developing as a result of the hyperestrogenemia. These are pulsating fine vessels radiating from the center about 1 centimeter in diameter. They are often found on the neck, face, shoulders, hands, and excess estrogens is the cause of this sign. And the excess estrogens in the blood are also associated with other symptoms that may be revealed on inspection, as hepatic tongue, raspberry tongue, or uni or bilateral enlargement of the mammary glands in men, with decreased hair on the chin, chest, and abdomen. Hair growth also decreased in women, but in armpits and on the pubis. Drumstick fingers and the Pediatrik fingers, they're sometimes with white nails, occur in patients with chronic disease of the liver. And it's believed that caused by excess estrogens and serotonin in blood. Signs of this suggest, other signs suggest liver failure include asterixis or a coarse flapping tremor, which occurs in hepatic encephalopathy. And other signs may be the Dupuytren contracture is linked with alcohol-related chronic. Another important and common sign of the liver and gallbladder disease is the jaundice, a yellowish discoloration of tissues resulting from deposition of the bilirubin. Jaundice seen if values exceed 3 milligrams to deciliter, and is best seen at palate, under surface of tongue, and clearly detected in daylight. The common causes of jaundice are demonstrated in this slide. The first is prehepatic jaundice due to hemolytic disorders, and the complexion is the pale lemon, and it's called flavin icterus. The second is hepatic jaundice. It's caused by hepatocellular disease. The complexion of patient is reddish shade, or called rubin icterus. And the last one is the posthepatic cholestatic jaundice, and the complexion of patient is greenish shade, and it's called verdin icterus. And this slide demonstrates shades, colors of jaundice. First is the greenish yellow, verdin icterus in abstraction of the common bile duct. Second is reddish shade, rubin icterus in patient with hepatitis, and lemonish yellow, flavin icterus in patient with hemolysis. This is the third one. And in prolonged obstructive jaundice, the color changed, the hue changed, and it becomes grayish or blackish green. This slide demonstrates two different signs. The first is the Kayser-Fleischer ring. This encircles the iris of the eye. Due to the copper deposition, this is the sign of the Wilson disease, a low blood ceruloplasmin level. And the second one is the senile ring found in patients with hypercholesterolemia. In patients with liver cirrhosis associated with disordered cholesterol metabolism, cholesterol is deposited intracutaneously in the form of the yellow plaques. They are called xanthomatosis. They are often located in the eyelids, and they are called xanthelasmas, and they're less frequently in other parts of body, in the hands, elbows, and soles. They are called xanthomas. Xanthomatosis occurs also in other diseases, for example, in atherosclerosis, diabetes, in essential hyperlipidemia. Important diagnostic symptoms can be found during inspection of the abdomen. One of them is abdominal enlargement or abdominal swelling. The abdomen may be enlarged significantly due to accumulation of the free fluid in ascites. This occurs in liver cirrhosis concurrent with the portal hypertension. The abdomen may be enlarged due to pronounced hepatosplenomegaly. And when the patient with ascites stands erect, his abdomen becomes pendulous. In the lying position, the abdomen is flattened, or so-called frog belly. The navel often becomes protruded in ascites when the patient stands erect. It is due to increased intra-abdominal pressure. This sign can be used to differentiate between enlargement of abdomen in ascites, also large intra-abdominal tumors, and pronounced obesity. In this case, the navel is retracted. Inspection of abdomen can reveal another important symptom of portal hypertension, the presence of dilated venous network on the anterior abdominal wall. This network is formed by anastomosis of portal and both vena cava systems. Dilated, swollen, and twisted venous collaterals they found around the navel and radiating from it. They formed the so-called Medusa's head or caput medusa. The reason of this sign is that in the setting of portal hypertension, blood finds alternative pathways back to the heart and do not pass through the liver. This also causes esophageal varices, which can bleed profoundly but are not visible on physical examination. Lower extremity edema is a result of liver disease, and the main cause of it is impaired synthesis of albumin. This causes lowering of intravascular oncotic pressure, and this leads to leakage of fluid into the soft tissues. And by the end of this part of our lecture, I would like to give an example how to group the signs found on visual examination and make a preliminary decision about the disease. For example, spider angiomata, palmarythema, hemorrhages, and red lips and tongue, gynecomastia, xanthomas, and clubbing fingers, they are known as the minor signs of the liver cirrhosis. Percussion of the liver is the second step of objective examination in liver and hepatobiliary system diseases, and this method is used before palpation. Percussion is used to determine the border, size, and configuration of liver and performed with the patient in horizontal position. The superior and inferior borders of the liver are outlined. Two superior borders of liver dullness are distinguished: relative dullness, which is the true upper border of the liver, and absolute dullness, this is the upper border which is not covered by lung. Practically, absolute dullness is determined only. The liver usually becomes enlarged in the downward direction, and this is determined by the position of the inferior edge. Liver produces a percussion dull sound. Percussion of the liver is performed according to the general rules of topographic percussion. The position of pleximeter finger should be collateral to the border, which is necessary for determining. Percussion, a clear sound to dull border, designate from the side of the clear sound. Quiet percussion is used to determine the absolute liver dullness. The direction of percussion is from top to bottom along the vertical lines, and the like in determining the borders of the right lung. The found border for each vertical line is marked on the skin by the upper edge of the pleximeter finger. Superior border absolute hepatic dullness is determined on parasternalis midclavicular right anterior axillary lines by percussion on intercostal spaces. In norm, The superior border of absolute hepatic dullness passes on right parasternal line at the level of the upper edge of the sixth rib, on midclavicular line at the level of inferior edge of the sixth rib, on anterior axillary line at the level of inferior edge of the seventh rib. For determination of the inferior border absolute hepatic dullness, the lightest percussion should be used. The inferior border of absolute dullness of a liver is defined on anterior axillary, midclavicular, parasternalis, right lines, anterior midline, and parasternalis left lines. Determination of the inferior border of absolute dullness of liver according to Obraztsov and Straszewski method should begin from the right part of the abdomen, along the right anterior axillary line. The pleximeter finger is placed parallel to the expected inferior border of the liver, some distance away from it. As the pleximeter finger is then moved upwards, tympany is followed by absolute dullness on the inferior edge of the pleximeter finger. When determining the left border of the liver dullness, the pleximeter finger is placed perpendicularly to the edge of the left costal arch at the level of the 8th-9th rib, and percussion is carried out on the right directly over the edge of the costal arch to the point where tympany changed to dullness. Normally, the inferior border or absolute dullness of a lying patient with normothenic chest passes at the level of the upper edge of the 10th rib on the right anterior axillary line at the inferior edge of the right arch in the midclavicular line 2 cm below the inferior edge of the right costal arch in the right parasternal line and 3-6 cm away from the inferior edge of the xiphoid process on the anterior median line. On the left parasternalis line at the level of the inferior edge of the costal arch. If the patient is in the upright posture, the lower margin of the liver descends 1 and 1.5 centimeters. If the liver is enlarged, its lower margin is measured in centimeters from the costal arch and the xiphoid process. Percussion gives information about the vertical dimensions of the area of liver dullness. The distance between the superior and inferior borders of absolute dullness is measured on the 3 vertical lines. The distance between the superior and inferior borders of absolute dullness of a liver compounds the height of absolute hepatic dullness. This distance in the right anterior axillary line is normally 10-12 centimeters, in right midclavicular line 9-11 centimeters, and in the right parasternal line 8-10 centimeters. Outlining the liver percussion is diagnostically important, but ascending or descending of superior margin of the liver is usually associated with extrahepatic change. Elevation of inferior margin, it indicates diminution of the liver. It can also occur in meteorism and ascites. The lower border usually descends when the liver is enlarged, but it can sometimes be explained by low position of diaphragm. Examination of size by of the liver is possible according to Kurloff method, and in this method 5 points are made and 3 dimensions are taken. The first and second points of Kurloff correspond to the superior and inferior borders of absolute liver dullness on the right midclavicular line. The first dimension of the liver according Kurloff is measured between them. In norm it is 9 centimeters. The third point of Kurloff is made at intersection of anterior midline and the perpendicular line installed from the first point of Kurlov. This is the level of the superior border of absolute liver dullness on the right midclavicular line. The fourth point, according Kurlov, is marked on the inferior border of the liver on the anterior midline. The second dimension of the liver, according Kurlov, is measured between the superior and inferior borders of the liver on the anterior midline. In norm, it's 8 centimeters. And the fifth point, according Kurlov, corresponds to the left border of the liver dullness. The pleximeter finger is placed perpendicularly to the edge of the left costal arch at the level of the 8th-9th rib between the left anterior axillary and midclavicular lines. And quiet percussion is performed to the right, directly over the edge of the costal arch to the point where the tympani changed to dullness. And the third dimension of the liver, according Kurlov, is measured between the third and fifth points of Kurlov, and this is in norm about 7 centimeters. An increase of the second and third dimensions is testifies a pathologic process of the left hepatic lobe, and increase in the first dimension. This is the pathology right hepatic lobe. For revealing a free fluid in abdominal cavity, percussion in a vertical position of the patient is performed. By percussion on midline and lateral flanks from top to down, it is possible to differentiate the tympanic sound over the intestines and dull sound over the fluid. In a horizontal position of the patient, percussion is performed on midline from umbilicus to epigastrium and hypogastrium, and in lateral directions from umbilicus to flanks. To determine the free fluid, percussion is repeated in lateral directions from umbilicus to flanks. In position on one side of the patient, in the presence of ascites, the level of dull sound is changed, which is called shifting dullness. Assessing for a fluid wave. If the abdomen is tensely distended and there is no certainty about the ascites, check for a fluid wave or fluid thrill. This maneuver is performed as follows. Place the palm of your left hand flat against the left side of the patient abdomen and flick a finger of your right hand against the right side of the abdomen. If you feel a ripple against your left hand, ask an assistant or the patient to place the edge of his hand on the middle of the abdomen. This prevents transmission of the impulse via the skin. If you still feel a ripple against your left hand, a fluid thrill is present, and this sign is only detected in gross ascites. The next step of examination is palpation. Before you start the examination, stand on the patient's right side. Begin with superficial examination to reveal a tender zone in the right hypochondrium and epigastrium, for example in acute cholecystitis, a slight or moderate tenderness at the point of projection of the gallbladder in chronic cholecystitis. In healthy subjects, this point is found immediately below the right costal arch by the lateral edge of the right rectus abdominis muscle. Palpation of liver by Obraztsov and Straževska method. Purpose of this examination is detection of the inferior edge, definition of its location, form, consistency, character of surface, and tenderness. As the lower edge of the liver descends during a deep inspiration, it meets the examiner's fingers and slides over them. This palpation is passive, as the active role belongs to the liver's respiratory mobility rather than to the palpating fingers. Position of the patient. The patient should lay horizontally with slightly raised head. His hands along the trunk or are crossed on the chest to restrict the mobility of chest to the sides on inspiration. This maneuver increases the diaphragm's motility that is important for palpation of the lower edge of a liver. Position of the doctor Doctor sits by the right side, facing the patient. He places his forefingers on the left hand on the right costal arch of the patient, and the left thumb pressing on the costal arch to move the lever closer to the palpating fingers and prevent expansion of the chest during inspiration. The 4 moments of deep sliding palpation must be taken into account for palpation of the lever. The first moment is position of hands. The right hand is placed on the region of right hypochondrium on the right parasternal line with slightly bent fingers. The tip of the fingers should be 3-5 cm lower than inferior borders of the lever found on percussion. The second and third moments are united and performed during the 1 expiration by dislocating the skin falls downwards and making an artificial pouch by dipping the hand into abdomen. At the 4th moment, the patient is asked to take a deep breath. The lever descends, touches the palpating fingers, and then slides under them. Palpation of the lever can be repeated several times. The lower edge of a normal lever is usually palpated between the right parasternal and midclavicular line. An enlarged lever can be palpated in all lines. If you feel a lever edge, describe its size, the sharpness, the smooth or its round, surface, smooth or irregular, consistency, soft or hard, tenderness, and whether it is pulsatile. According to Obraztsov, normal lever can be palpated in 88% of cases. The margin of normal lever is palpated at the height of a deep inspiration 1-2 cm below the costal arch. It is soft, sharp, or slightly rounded, readily bending. It is smooth and insensitive. A palpable lever is not necessarily enlarged or diseased, but increases the likelihood of hepatomegaly. The vertical lever span and overall clinical context must be also considered. A non-palpable lever edge does not rule out hepatomegaly, but does reduce it. An alternative method for palpating the liver is hooking method, when hands hooked around the costal margin from above. Palpation of gallbladder. The gallbladder cannot be palpated in healthy subjects because of its soft consistency and insignificant protrusion. But if the gallbladder is enlarged in hydrops, stones, cancer, it becomes palpable. The position of patient for palpation of the gallbladder is the same as in palpation of the liver. The gallbladder should be palpated at the intersection of the right costal arch and lateral edge of the right rectus abdominis muscle. This slide demonstrates diagnostic signs used in inflammation of gallbladder. They are based on occurrence of pain during examination. Supplementary examination methods. Laboratory tests. They are used for assessment of the severity of liver injury, for detecting the hepatic dysfunction, monitoring the course of liver diseases and their response to treatment, clarification of diagnosis. The most useful laboratory tests to screen for liver disorders are subdivided into the following groups. The first one is group for biochemical test for detecting the hepatocellular injury. Alanine aminotransferase, ALT, and aspartate aminotransferase, AST, they leak from damaged cells. Therefore, they can be considered as indicators of the liver injury. As AST is present in the other organs as heart, skeletal muscles, kidneys, and pancreas, it may be increased in the injury if one of these organs. In most liver disorders, the ratio of AST to ALT must be considered. In these cases, it is less than 1. Test for cholestasis. Increase in level of conjugated bilirubin shows obstruction of the bile excretion. When associated with other liver test abnormalities, a high serum bilirubin indicates hepatocellular injury. Alkaline phosphatase is another indicator, but an increase in levels of AP may be nonspecific because it consists of several isoenzymes and has a widespread extrahepatic distribution. For example, in small intestine, in white blood cells, in kidneys, and particularly bone. AP levels increase to more than 4 times in 1 or 2 days after onset of biliary obstruction. And levels of gamma-glutamyl transpeptidase is more specific to the liver. GGT levels is an enzyme increase in hepatobiliary dysfunction, but alcohol and certain drugs, for example, warfarin, they markedly increase GGT and thus somewhat limiting its specificity. Another set of tests, they are tests for detecting of the hepatic synthetic capacity or for detecting the liver cell failure. Prothrombin time, PT, and International Normalized Ratio, INR, they are the valuable measure of the liver's ability to synthesize fibrinogen and vitamin K-dependent clotting factors. They are factors 2, 7, 9, and 10. Abnormalities indicate the severe hepatocellular dysfunction. The PT and INR does not increase in mild hepatocellular dysfunction. Prolonged PT and abnormal INR can result from coagulation disorders such as vitamin K deficiency. Fat malabsorption, including cholestasis, can cause vitamin K deficiency. Hepatocellular dysfunction can be ruled out if vitamin K replacement corrects PT by more than 30% within 24 hours. Serum proteins. Hepatocytes, they synthesize most serum proteins, including alpha and beta globulins, albumin, and most of clotting factors. Liver cell failure causes decrease in the levels of serum proteins as well as the cholesterol. Mesenchymal inflammatory syndrome laboratory tests, they are depicted in this slide. And some of them, they are specific for certain diseases, and some of them, they are not specific and they have no clinical significance in some cases. And by the end of this section of my lecture, I would like to demonstrate a slide that reflects the differential diagnostics of jaundice. Here are the clinical features, anamnesis, laboratory test results. And the last part of my lecture is dedicated to instrumental diagnostics of diseases of liver and biliary tract diseases. The first one is imaging tests. Ultrasonography, traditionally done transabdominally and requiring a period of fasting, provides structural but not functional information. This is the least expensive, safest, and most sensitive technique for imaging the biliary system, especially the gallbladder. Ultrasonography is the procedure of choice for screening for biliary tract abnormalities, for examination of patients with right upper quadrant abdominal pain, for differentiating intrahepatic from extrahepatic causes of jaundice, and screening for liver masses. Ultrasound elastography. They can measure liver stiffness as an index of hepatic fibrosis. Elastography is often used in combination with blood tests to assess hepatic fibrosis, particularly in patients with chronic hepatitis C. Doppler ultrasonography. This is a non-invasive method. It's used to assess direction of blood flow and patency of blood vessels around the liver, especially in the portal vein. Magnetic resonance imaging, MRI, is used to image blood vessels, ducts, and hepatic tissues. MRI is superior for diagnosing diffuse liver disorders, for example, fatty liver and hemochromatosis, and for clarifying some focal defects. MRI also shows blood flow and therefore can be used in diagnosis of vascular abnormalities and vascular mapping. Computed tomography, CT, is commonly used to identify hepatic masses, particularly small metastases with a specificity of more than 80%. It is considered the most accurate imaging technique. CT scan can be used with contrasting if needed. Radionuclide liver scanning. It shows the distribution of an injective radioactive tracer, usually technetium, which distributes uniformly within the normal liver. Lesions more than 4 cm, such as liver cysts, abscesses, metastases, and tumors, is shown as defects. Cholecystography detects bile leaks and anatomic abnormalities. After cholecystectomy, this method can quantitate biliary flow. Biliary flow helps identify papillary stenosis or sphincter of Oddi dysfunction. Endoscopic retrograde cholangiopancreatography, or ERCP. ERCP provides detailed images of much of the upper gastrointestinal tract and their preampullary area, biliary tract, and pancreas. This method can also be used for biopsy. Because it is invasive, ERCP is used for more treatment than for diagnosis alone. ERCP is procedure of choice for treating biliary and pancreatic obstructing lesions and for removal of bile duct stones and stenting of strictures. Liver biopsy plays an important role in modern clinical practice. Biopsies can be targeted, surgical, or medical to allow assessment of the liver parenchyma in general. Liver biopsy is generally a safe procedure, but it's invasive. This procedure has been considered as the gold standard for assessing the stage and grade of chronic liver diseases. Liver biopsies are usually obtained via percutaneous approach using ultrasound guidance. In conclusion, I would like to note that all above-mentioned methods of examination allow the doctor to clarify the final diagnosis and prescribe the correct treatment. Thank you for the attention.